Moving into imaging, we're going to talk about ultrasound, chest x-rays, CTs, ventilation perfusion scans, pulmonary angiograms, MRIs, and MRAs. Some of the things that we can do with the ultrasound is it will detect clots in the thigh veins. So we can do what's called a DVT screening to look at the lower extremity vessels to see if there are any clots in the lower extremities. This is a non-invasive way for us to get this information, and it can be done in 30 minutes or less. Most of the time, it is very accurate for diagnosing blood clots behind the knee or in the upper thigh. It's really not very sensitive. It's insensitive for detecting DVTs below the knees. When we look at the chest x-ray, typically it's going to look fairly normal. But when you do have some of those one-off cases, you're going to have infiltrates or atelectasis that's seen in about half of your chest x-rays where your patient has a PE. You will see infiltrates and atelectasis, especially when there are like pulmonary infarctions that are involved. About 40% of the time you'll see an elevated hemidiaphragm, so you'll start to see the one of the diaphragms start to slide up, and the telltale sign is a Hampton's hump, and I'm going to talk about and I'll show you the Hampton's hump here in just one second. When we look at CT angio or CT pulmonary angiogram, what we're talking about is injecting an IV contrast, and this is becoming more and more preferred over the previous gold standard, which is the VQ scan. So this had been the gold standard. We're shifting the gold standard to be the CTPA or the CTA. The scan requires an IV line, but when we get these pictures, the resolution of these pictures are so incredibly good that we can see everything that's going on. And when we're looking at this, it doesn't take very long to get a CTA. The entire chest can be scanned with a single breath or in a short amount of time, succinctive or consecutive breaths with a short breath hold. So that's one of the things that we ideally want to do when it comes to the CTs of the chest, is we want the patient to be able to do a breath hold. When we look at the VQ scan, this is the ventilation perfusion scan. We're looking at nuclear medicine at this point. When we look at the VQ scan, it's rarely used today. The reliability is only really with extremes of a pulmonary embolism, and it sometimes raises more questions than answers. And now that we have the ability to do these CT angiograms, the CTA or the CTPA is really replacing these VQ scans. Another thing that we can do is we can call the cath lab team in. We can call the cath lab team in and do what's called a pulmonary angiogram. And basically what we're doing is we're looking at the blood flow in the lungs, specifically the arteries. And this is extremely accurate for diagnosing the PE. However, it is an invasive procedure that calls us to get the cath lab team in, or interventional radiology in, to perform this procedure. A catheter is inserted into the artery and a dye is injected, and then from that you get a diffusion pattern, or you get to see the blood flow around the pulmonary system and looking for those PEs. This is a very time-consuming process. It takes about an hour, if not more, and it takes a very highly skilled practitioner to perform these. So we pull this out when we have not gotten our information from the ultrasound, the chest x-ray, or VQ scan. So we pull this out if we're not able to get that information from some of the other diagnostic tools or imaging tools that we have. And there's much more dye that is used in comparison to the CTA. So we want to make sure that when it comes to that dye, a lot of times patients can, this dye can impact the kidneys, and we want to make sure that we keep all the other organ systems well taken care of. And that really allows me to move right into the MRI here. So MRI, we would use this for patients whose kidneys would be harmed by the dye. So if I've got a patient who's in acute kidney failure, my CTPA and my pulmonary angiogram are kind of going to be out of the question, just because I don't want to damage an entirely different organ to identify what's going on. The other area where we would use the MRI is with women who are pregnant. So we don't want to inject the dye or expose them to nuclear medicine or radiation with these other procedures. The MRA really differentiates among blood, thromboembolisms, and tumor emboli in patients with malignancy. So we're using this for a specific patient population as well. So those that may have malignant tumors that are migrating or navigating. So here is our chest x-ray. This right here, this triangular or wedge shaped that we see, this is a telltale sign for a pulmonary embolism. But we won't see this very often. This is a rare sign of a pulmonary embolism. But when you see this pizza shaped, you see this pizza shaped, wedge shaped opacity, it's actually pointing at the pulmonary embolism and where it's located. So we want to just make sure that if we see this pizza shaped or this pie shaped opacity, we're calling in a team. We're getting this patient taken care of. When it comes to the other factors and what we would see perhaps some atelectasis, areas of atelectasis, or we could even see a hemidiaphragm that's starting to elevate. So chest x-ray. Wells rule for DVT. So when we look at this, this is a list of information. This is a list of information that identifies the patient's likelihood of having a DVT. So you get point values 1, 1, 1, 1, 1, 1, 1, 1, 1, 1, or a -2 that help identify if this patient is at risk for a DVT. If you ask these questions, or if you answer yes to these questions in your assessment, then it adds that point value to your assessment. Any point value that's greater than 3, they are at a high risk for a DVT. Anybody that's less or that is a 1 to 2 has a moderate risk for a DVT. And anybody that has a Wells rate less than 1 has a low rate or low probability that they will have a DVT. So this is part of our assessment, especially when it comes to somebody that we may be suspect to emboli. We would definitely ask these questions so that we can identify our risk when it comes to this condition. When we look at the Wells prediction rule for a PE, the one previously was looking at a DVT. This is looking at a PE for sure. And when we look at this, we use 3, 3, 1.5, 1.5, 1.5, 1, 1. So no points or no questions in this questionnaire do we get any negatives like we do with the predictive rule for DVT. For PE, it is all yes and all adding to the overall score. So when we look at our scores here, if the score is greater than 6, they have a high risk for a PE. If it's 2 to 6, it's a moderate risk. If it's less than 2, we have a low risk of a PE. So the Wells prediction rule for PE uses 3s, 1.5s, and 1s. The Wells prediction rule for DVT uses all 1s with the exception of one question, and that leads to a negative valued result. Hemodynamics. So hemodynamics, we're going to be very specific and we're going to look at our pulmonary artery pressure. Normal pulmonary artery pressure is 25/10. with a mean pulmonary artery pressure of 15. Anytime that we see that mean pulmonary artery pressure greater than 20, we need to be suspect of APE. Remember, how do you get these hemodynamic values? Well, you have to have a Swan-Ganz catheter or a pulmonary artery catheter in place for us to measure the pulmonary artery pressure, for us to measure the mean arterial pressure. So when we look at the mean arterial pressure, do you guys remember the formula for mean arterial pressure when it comes to systemic circulation? Yeah, 2D plus S divided by 3 gives you your mean arterial blood pressure. So when we're looking at our mean pulmonary artery pressure, we use that exact same formula, 2D plus S divided by 3. So 2 plus 10 is, or 2 times 10 is 20, plus 25 is 45, divide that by 3, you get 15. When my mean arterial pressure is greater than 20, when it's greater than 20, I want you to think pulmonary embolism. Okay? Everything on the left side of the heart is going to be decreased. So this is the output side, so our systemic circulation side. We're going to see that the pulmonary capillary wedge pressure is going to be decreased. The cardiac output, stroke volume index, cardiac index, left ventricular stroke work, and the stroke work index, and the systemic vascular resistance. Those will all be decreased or normal. When it comes to the right side of the heart, all of these values are going to be increased. My pulmonary artery pressure, my mean pulmonary artery pressure, my right atrial pressure, and my central venous pressure. Well, if I have all of that increase in PVR, if I have all of that increase in the PVR, then the right ventricle has to work harder. So the right ventricular stroke work index is going to be squeezing so hard to try to get all of that volume past or outside of the pulmonary vascular resistance, or to overcome its afterload is another way to say that.